Live.
Good afternoon, everyone, and welcome to the Health and Adult Social Care Scrutiny Panel meeting on Thursday, 24th of September. We have members with us today, myself, Habiban Zaman, I'm the chair, Councillor Afak Butt. We have co-optees David Rigby, Peter Bradshaw and Lynn Keedy. We have apologies from Councillor Liz Warner and Councillor Alison Munro. We will probably have Councillor Vivian Lees Hamilton joining us later. We move on to the agenda, item number 1, which is minutes of the previous meeting. And we have a look through the minutes and see whether we agree with them. Could we have somebody approving the minutes?
I'd support that, Chair. Thank you.
Anybody second?
Yep, I can second that.
Thank you. Item number 2 is interest. Do any members have any interest to declare? Can you please disclose them now?
Yes, if I can just declare I'm an ordinary member of SWIFT.
Thank you. Anybody else? Okay, thank you. This is a live meeting which is taking place in public and is being live streamed. We have no deputations and petitions for this meeting. Item number 5, public question time. We have no members here asking public questions, and we move on to item number 6, which is Kirklees care homes. And if I could invite Richard Parry to take us through the report.
Thank you, Chair. So I'm Richard Parry, I'm Strategic Director for Adults and Health at Kirklees Council, and I'm going to talk us through the first part of this report and hand over to my colleague Julie Oldroyd, who works for the 2 Kirklees CCGs. And what I'm proposing, if it's okay with you, Chair, is that we work our way through the report and then take questions at the end.
Any questions on the report?
Would it be helpful, Chair, if I just talked us briefly through the report?
Yeah.
Okay, thank you.
I mean, we have discussed the report. You know, it's up to you if you want to just go through the key highlights. Okay,
so I think I want to start by reflecting that there is a long history now of joint working between the Council and the 2 CCGs in relation to care homes, and that particularly started after the closure of a care home called Oxford Grange about 3 years, and some panel colleagues may recall that item coming to the scrutiny panel about 3 years ago, and that led to much more of a join-up between the 2 CCGs and the Council in terms of our support offered to care homes. That's been an important foundation for the work over the last 6 months in supporting care homes during the COVID period, and sits alongside a number of other initiatives that were already in place or were being planned. So, for instance, the Enhanced Health in Care Homes framework that was being mobilised. As you'll see, there's been quite a lot of activity. We've recently convened a care home programme board to further improve coordination of all of that activity. What we recognised was that the number of initiatives, and the learning from Oxford Grange had been that whilst individual initiatives are helpful, it's important that there's a degree of coordination so that we're really clear how those are pulling together to contribute best to supporting care homes, and care homes don't either get overwhelmed with initiatives or we've got gaps opening up. A lot of the focus has been around making sure that we're providing very practical support in terms of infection prevention and control into care homes. You will recall, I'm sure, panel members, early national headlines about the impact of COVID-19 in care homes, That led to quite a lot of work through NHS England and through CCGs to improve and coordinate the support offer to care homes, which sits alongside the work that our existing council infection prevention and control colleagues have been doing. And that was very much about a training offer through to care homes, both in person and in a virtual manner, to help make sure that care homes were clear about how to use PPE and other infection prevention and control measures. What's been clear is that whilst that was initially successful, when we've gone back and tested some of that out with care homes, as they've had staff turnover and perhaps as staff have been working in the same way for a number of months, there's the potential for gaps to emerge. So what we are doing is designing a new programme to go back out, re-engage care providers and staff around that continued focus on infection prevention and control. We've also got sat alongside that, as you see, work around the flu vaccine programme for this year. More than ever, that has been going to be critically important in both protecting care home residents, but also ensuring that care home staff are protected against flu and the risk of either being unwell and therefore unavailable to support residents, or transmitting that within the care home. I wanted to just pick up finally on some of the financial support that's been provided to care homes. Care homes obviously experience significant additional running costs through things like additional PPE requirements, as they are using more and it is costing significantly more. At times there have been gaps in PPE availability, which the council has helped fill through a distribution hub that we've been running. And providers have care home providers have seen an increase in vacancy levels. So that's a combination of two things. Sadly, a number of people passing away, particularly in that kind of March, April, May period, and fewer people during that period moving into care homes. What we're seeing is we're seeing a significant change in both of those trends now. So we're seeing the numbers of people moving into care homes increasing, and the number of people passing away is significantly reduced, but nonetheless that has left care homes with more empty beds than they would normally have expected to see, which is carrying a financial pressure, represents financial pressure to care providers. So we've been running a programme of financial support which runs through to the end of September around a number of the additional costs that care organisations have faced. And ours, a number of councils have done that. Ours has probably been running for slightly longer than other councils, but is an important part of making sure that we've got viability for care homes. Then sat alongside that, we've commissioned some work, an independent organisation to come and work with us as a council and with care home providers to really start to describe what the future care market will look like in terms of demand, so that providers can plan for that longer term. So I was at this point going to propose handing over to Julie so that she can briefly run through some of the additional NHS offer that's been made available to care homes to make sure they've got a good, safe practice.
Hi everyone, thank you for inviting us along. I'm Julie Oldroyd. I'm a Lead for Transformation across Greater Huddersfield CCG and North Kirklees CCG, and I've been very much involved in the care home work, especially over the summer months. So the elements that Richard alluded to just then was during the COVID period, the general practice were asked to put some extra support into care homes, and we set up a weekly check-in process with our practices. So every practice we're ringing the care homes on a weekly basis, asking if there's any residents that needed clinically assessing. That's worked really well, and we also identified a clinical lead for every care home as well on behalf of the PCNs, as well as providing some extra medicines management support into care homes. And moving forward, on point 7.8, we did put in some support around equipment. So we provided care homes with equipment such as pulse oximeters, thermometers, and blood pressure equipment, so that they could do some clinical observations that would assist any remote video consultations with the practices, and that was all very much well received. One of the largest things that we've worked on is around the capacity tracker. This is a tool that was available before the COVID period, but it's kind of gained momentum during that time and become really important. And that's a tool that the care homes complete every day to describe how many bed vacancies they've got. But during COVID, extra things were added to this tool, so they could report on COVID infections, whether they got enough PPE, if they've got any workforce problems, and more recently they can report on testing and any mutual aid support they might be receiving. So nationally, the capacity track has become really very important, and our care homes have done really well at updating it every day mostly, and certainly every week. So that's a watching brief, because I think the ask of that will increase over the coming months, and it will become more and more important, and there'll be more asks of the care homes to complete it. Also, the enhanced health in care home DES, direct enhanced service, will come into being from the 1st of October, and that builds on some of the stuff we've done through COVID. So it builds on the weekly home rounds and having a clinical lead again, as well as making sure residents get structured medication reviews, personalised care planning. We have actually managed to do something over and above the national ask around this. So we've managed to align every single care home to one practice, which is a real achievement, to be honest. We had sometimes 8 or 9 GP practices going into care homes, which made communication and relationships difficult. So over the summer, we've managed to align every care home to one practice, and that should have a massive improvement around communication and relationships between the two. Under 8.2.3, there's other achievements we've managed to do over the summer months, and certainly around capacity tracker, we've done very well, as well as all care homes now have an nhs.net address so they can share data. The paper then goes on to talk about our quality strategy, which includes a process for reporting any concerns, and we've also got a section on workforce of the things we want to do over the coming 12 to 18 months around it, supporting workforce in care homes. And then we've got a summary. I don't know whether Richard wants to talk to the summary element.
Thanks, Julie. I'm mindful the colleagues on the panel have had the report, so hopefully the summary should be self-evident from that.
Okay. Can I just ask a question on page 17, where you've got this task and finish group? Is that a group that was set up specifically since COVID started, or is it one that's been set up previously?
The panel members.
So I can't see the numbers on my pages, sadly, but I think a lot of the task and finish groups are fairly new. So the programme plan we've developed has kind of brought all areas of work across the system into one big programme of work, and as part of that programme we're identifying new task and finish groups to take pieces forward.
Thank you for that. Okay, if I open it to members to ask questions. David, you've got your hand up.
Yeah, thanks. There were 3 kind of overall points I wanted to make first of all. First of all, thanks very much for the report. That was comprehensive, so a lot of good information in there. I think it might be useful, if possible in future, on these kind of reports, to have a summary section which just picks out the key issues, and also a very brief reference to what action's been taken about those key issues, or what actions planned for the future. I'd just find that helpful, given there's a lot of information in the report. And the other 2 overall points are, first of all, if you could just comment on whether there are any current problems with the availability of PPE or anticipated through the autumn, and the other issue is around testing, whether there are any current problems in getting access to testing. Thank you.
Shall I pick those up, Julie?
If you like, yeah, I'm happy to chip in if you need me.
So in terms of PPE, no, we've now, as a council, hold a significant stock of PPE both to support council activity, and we made that stock available to care homes when needed previously, and stock that's come through the local resilience forum that we hold for external organisations such as care homes. And that stock's really just is available to deal with interruptions in their supply, but by and large, providers now have good access to PPE through the business as usual routes, through the normal suppliers that they would have used. In other words, production and so on, distribution has caught up with demand. The same is not the case for testing. We know that, so through the care home tracker that Julie described earlier, we know that providers are indicating a lack of confidence in testing arrangements. So that's the ability to get test kits into care homes, for them to be collected in a timely way and for them to get results back in a timely way. And so no, there's an absence of confidence in the sector at the moment around those testing arrangements.
Thank you. Peter?
Thank you, Chair. Probably one for Julie, I think. I wanted to ask Julie a couple of things. First one was about the nature of infection and prevention control training, and I just wondered what this comprised, because I think Richard actually described some of the problems in care homes. You've got a fleeting group of staff who are not there the whole time, and I just wondered, whilst I'm sure that going in and doing whatever you did, is very, very valuable, but is there anybody there to see that it carries on when you've left?
Yeah, I mean, they did an immense amount of training during the summer, and a lot of that was train the trainer type training that was cascaded.
Yes.
The capacity tracker probably helps us with some of this, because the capacity tracker reports, the carers report if they're having problems with infection control, and if they've got training needs. And that is picked up every day. So every day we have a process of looking at what the care homes are saying on the tracker, and then the care homes rate themselves as amber and red if they've got a problem, and we report that to our infection control team, who'll contact the homes that day to see what the issue is, and then we'll put in whatever actions are needed. So if there's some extra training needed or some advice and guidance, they act on it on a daily basis.
When you talk about amber and red, is that determined by the amount of, is that determined by microbiological information, or what you think the staff, is it determined by what the staff are telling you? Yes,
it's more it's more of a self-assessment from the care home if they're struggling with any element, and so if they say they're struggling, we're in touch. But alongside that, the infection control team receive reports from Public Health England anyway every day, and so they know what the rates are of COVID, all the reports, and they're also already in touch with the homes who've got 1 or 2 residents or more with COVID on a daily basis as well. So there's kind of 2 routes to be monitoring support around infection control.
Yeah, because presumably the milieu in a care home is not the same as in a hospital ward, and the whole arrangements for instance, isolating somebody who's got a communicable disease are not necessarily easy.
Not at all, especially in dementia homes, learning difficulties homes, the disabilities homes, it's more difficult. But the infection control team are there to offer that support and guidance around that.
Yeah. So what are the liaison arrangements? Is there somebody in? I mean, because it's obviously terribly important. This, if you've got a new case, you want to kind of segregate it, and you don't want the rest of the community to get it. And I know it's a big ask that they don't. But what are the arrangements between yourself?
The care home reports to Public Health England of any cases, and as soon as they've reported cases, the infection control team are involved, and they contact the home on a daily basis and offer advice and guidance. So they would offer advice around isolation. If the care home's struggling, then they will try and help out with that, and even visit the care home if need be. So there's quite an intense support mechanism around this, but right. it is very difficult, and more so in certain homes. I agree.
Thank you. And then my second one, please, if I can just ask about the actual operation of the clinical services model. And I wondered who the clinical lead is in this scenario that you describe.
So during the COVID period, each primary care network identified one clinical lead for the whole of the care homes in their network, and the care homes were introduced that clinical lead, and they kind of picked up any strategic issues. But now we've got the Enhanced Health and Care Homes DES, which starts on the 1st of October. The clinical lead largely will be within the practice, so each care home's aligned to one practice, and that practice will identify a lead GP or nurse to be the link to the care home. And we're just in the process of doing that, to be honest.
And presumably the PCN involvement is by it's remote. We're not going to actually get doctors going into care homes, are we? Surely,
No, at the moment it's all remote. So because during the summer we had the weekly check-ins, the care homes have got used to doing remote kind of consultations. So that will continue.
Yeah, and I mean, general practice doesn't do anything for nothing. So presumably there's some remuneration for practices.
In the summer, we provided some funding to do the weekly check-in because that was there was no other funding. But now we've got the DES. The DES provides funding, so the DES pays £120 per resident per year for a number of things, including the weekly check-ins.
Yeah. And where does Locala come into all this?
So Locala provide the general support into care homes that they always have, the district nurse, the community matrons, that kind of thing, as routine. In Greater Huddersfield, we commission a separate service called the Care Home Support Service, and they provide some extra support in the form of reviewing people as soon as they go into the care home, and providing a review if they've been discharged from hospital, as well as an annual medication review. And they also do a lot of advanced care planning, so identifying people who might be coming towards end of life and putting care plans in place. That service we want to replicate across Kirklees, so we're in the process of doing a business case to try and make sure that service is across Kirklees. But during the COVID period, we have funded for some of that service to happen in North Kirklees as well. So we've certainly got some of the team working into North Kirklees on a temporary basis and doing the advanced care planning very much. And there's been a real focus on that across the patch. Yes, so that hopefully will continue. So
that will be nursing care kind of over and above what a care assistant would generally be expected to give.
Yes, so it's like a holistic assessment, looking at the person as a whole, health and well-being and mental health as well, and agreeing sort of a personalised care plan per resident to work for the home to work with, and for the resident to be obviously they're part of that conversation in agreeing a plan, as well as identifying people who need an emergency care plan to stop them being admitted to hospital unnecessarily, or an advanced care plan, which is more about end of life.
That's what I was interested in, really. Is it saving hospital admissions?
Absolutely. So the Huddersfield team have demonstrated for the last 3 years that they reduce every year on year. They've reduced hospital admissions, and that's why we want to replicate that service across, in a recurrent way. So we have got it in North Kirklees since the summer, but we need to make that a recurrent service.
Thank you very much. Thank you, Chair.
You're welcome.
Can I bring Lynn in now? Lynn, can you hear us?
Yeah, thank you, Chair. I've got 2 questions, please, on this report. My first one relates to point 3.1, and it talks about the Kirklees Care Home Programme Board, including senior representation from across partner organisations. And I'd just like to ask which organisations those are, please, the partner organisations.
Do you want me to take this, Richard?
Yes, thanks, Julie.
At present, it's a fairly new entity as a programme board. So at the moment, it's the CCGs and the local authority, largely with different members of different teams coming to in the programme board, but the plan is to spread that. So we will be including partners such as Locala, Swift, Kirkwood Hospice, and others as we think is appropriate. So that's a development, I guess. At the moment, it's mainly the CCGs and local authority coming together.
I presume as well that there will be the primary care networks represented within that too.
Yes, and also we want to start involving the care home managers as well. So we have got a care home provider forum where we're discussing just that and how they can input into that meeting, as well as into some of the task and finish groups around the programme plan.
Right, thank you for that. And my second question relates to 4.20 of the report, where it indicates that having regard to the further 11 care homes that came back to accept the offer of infection prevention and control training, there were clearly 28 care homes that didn't take up the offer. And I'm just wondering whether they were required to evidence what they did instead, please.
I'd have to take that question back to our infection control team to answer, because I can't actually give you that answer. Sorry. I will do though. I'll ask.
Okay, thank you.
I just wonder, it's worth noting we have a wide range of types of care home in Kirklees. So some are comparatively small operators that potentially a single care home or chain with a small number of care homes. Some care homes are members of fairly significant chains, regional, 30 plus homes that have got a fairly significant infrastructure around training and support. And some care homes, obviously part of national chains, that have got very significant capacity within their own organisation to provide advice, support and training. And so typically wouldn't have needed to take up a local offer, because actually they'll have people employed directly to deliver that training across all of their establishments. So the fact that some homes declined the offer, it shouldn't necessarily be read as they weren't interested. It's actually that they've got good alternative arrangements in place already and a very standardised way of delivering training across all of their homes in that chain.
And would you have been satisfied? Well, what steps have been taken to be satisfied as to the calibre of that training that they were going to provide? Please.
So I think in that we'd have been taking a view about the organisation. So obviously if it's a large national organisation, in a sense, ultimately the individual care home is responsible for the standards of care that they provide. We'd have taken a view about if there's a significant national or regional chain who was saying, actually, thank you, we don't need the offer. We'd have had a confidence about the alternative offer that they were able to provide themselves. And obviously, if it's a small local organisation, that they may well be able to do that. But as Julie says, I think we'd have done some more work around actually how they were intending to fulfil that need.
Okay, thank you for that. Thank you, Chair.
Thank you for that. We have a question from Dave.
Hi, yes. I've actually got 3 questions, if that's okay. The first one's on paragraph 413, and it's to do with the planned environmental IPC audits in care homes. And it says understandably that those aren't taking place currently. I just wondered, are there any plans to carry those out virtually in some way, perhaps working with the relevant care home managers so that at least part of the audit can be carried out?
Do you want me to say that, Richard, or do you want to answer that one? I think that's another one I probably need to take back to the IPC team for comments on. This paper was written by a number of different teams, so we pulled together lots of different views. I can't answer everything, but I will take it back and come back to you on that one.
Okay, thank you. And the second question is on paragraph 833, and there's a reference there on the first bullet point of it refers to individual experience and picking up on what those individual experiences are as part of the overall learning process. I just wondered, is that actually happening now?
Well, I think this it refers to kind of some of the drivers that have influenced the care home programme plan and the different elements within it. Certainly individual experience is part of that personalised care planning focus. So every resident should have a personalised care plan. It should be reviewed at least annually or more often. And part of that personalisation is listening to people's experiences and desires and wishes and coming up with an agreed way of meeting those and reviewing that and supporting how they might achieve those desires and wishes. So I think it's kind of an essence that runs through the whole of the programme. And certainly if you looked at the framework for enhanced health in care homes, it's really key that everything's personalised and individualised and residents are part of every decision about them and very much involved in all that.
Okay, thank
Probably
you.
worth adding, Judy, sorry, we've been working with Health Watch to get feedback from care homes and the experience of residents in care homes as an independent organisation.
That's good to hear. Yeah, thank you. And the third question is on paragraph 8.4 on the workforce. I just wondered what the current position is in relation to the use of agency staff. I know there have been some problems previously in terms of agency staff in the sense that they work in more than one home at once. And overall, what's the position regarding recruitment and retention within the workforce?
Do you want to pick that one up, Richard?
Yep, so we've already got established an organisation called Into Care that supports the care sector around recruitment and retention, and they've been working very successfully over the last couple of years. We increased their capacity in their work with care home providers to make sure that we had the capacity to deal with any recruitment challenges. In practice, what we found is that it has been possible to recruit additional care capacity across the system. So what we've seen, if you're looking at, for instance, the home care sector, you'd see we very significantly increased the availability of home care over the last year, and that has continued during the last 6 months. So we've been successful being able to recruit people into the care sector. In terms of agency, homes are obviously trying to minimise the amount of agency work. And we've been working with agencies so that they reduce the number of homes that agency staff would work with, so that whilst they may use agency staff, it's on a more exclusive basis. One of the other things we've been needing to do is work with care homes, because if they have a couple of homes in Kirklees, they would often typically have managed staffing capacity issues by moving staff between establishments. And again, that's effectively, increases risk. So there are times when agency staff are still being used because it's the only way in which they can safely manage staffing levels, but that's been done in ways that were different to done previously. And as we've started to get better access to testing, for instance, for care home staff, including agency staff, that has reduced some of the risk.
Thank you.
Thank you. Can I bring Councillor Liz Mage in if you have any questions before I bring Peter in?
No, I don't have any questions at this moment. Thank you, though. Thank you.
Peter, go ahead.
Thank you, Chair. Two things. One, probably you again, Julie, I'm sorry to say. I just wondered what you were doing within all this about calibrating the quality of care within each home and between one home and another, and how easy it was to spot homes that are what we might sensitively called vulnerable in terms of their quality of performance, and what you were able to do about it, please.
So the quality team very much have got a programme around that, so they can identify homes who might be struggling and put in support. They have a series of different meetings where any issues can be brought and raised, and they will follow that up. I'm not particularly involved with the quality team, but certainly there's a robust mechanism around looking at failing homes or struggling homes and how they can be offered support and linking with CQC, etc.
Yeah, so that's good to know, because the last thing you'd want in the midst of all this is for there to be neglect.
No, absolutely.
The highest care. And that brings me on to the second one, which I think Richard's alluded to this, and this is about the sort of financial support that is needing to be provided to to care homes and the whole business about their market sustainability. I know that you're studying this quite separately under another rubric, but I just wondered again how financially vulnerable some of these providers really are.
I think you're right. I think they are, and I think certainly over the summer that they had quite a number of empty beds, as Richard mentioned earlier. Although that feels like it's changing a little bit now. We've had various discussions around this, and the Care Home Provider Forum is something where these discussions have taken place and actions have been followed from that. So certainly over the summer we've looked at the paying for the voids, and now how we could financially support. But there will need to be some ongoing thought around that to keep that market sustainable. And we've also got a weekly virtual meeting that we hold to support the care home, so they can ring in. We've got a bit of a loose agenda, so any of the communications we've sent through in the previous week we can talk through in more depth, but we can certainly listen to any problems there, and they do raise issues that we can escalate then. So if anybody is worried, there's a couple of routes of escalation to provide support. I don't know whether you want to add anything, Richard?
Just to say, I think there's a dilemma here, which is the long-term vision and strategy for social care has been about supporting more people to remain in their own homes for longer. So that's the increased availability of home care, the use of assistive technology. Alongside that, we've obviously got an investment program in developing extra care housing, the development of more bungalows and other forms of housing that are easier to live in if you have some care needs. And so in the longer term, we would have expected demand for residential care to have remained fairly static or potentially decreased anyway. So we're in a space where there are a high level of voids. Care homes will always have an important role in the care mix, but actually we're also seeing increased opportunities for people to remain in their own homes, which would, in the longer term, which would have reduced demand for residential care anyway. So I think that's the importance of the piece of work we've commissioned with an external organisation to work with the council, the CCGs and the care providers to say, so actually what will the next 12, 24, 36, 60 months look like in terms of the care market, in terms of likely demand, so that we can then work with providers for them to adapt to that. And they're quite clear that what they want is to have that sense of intelligence about what may happen, so that they can adapt their business model accordingly, which may be about changing the nature of the care home, coming out of the market altogether, thinking about do they move into a kind of more of a supported accommodation and care model sat alongside their care home. So there's a number of opportunities. It's at this stage, like many things, I think we're in a bit of a limbo space where we know what's happened over the last 6 months. We're less clear what's going to happen over the next 6 to 12 months and how we support providers to adapt to that.
Yeah. And presumably in keeping financially vulnerable organisations afloat, there are Treasury rules about how far you can go.
There are, and as you say, it's a balance, because we need to recognise that care homes are a business, but at the same time, the consequences of them closing in an unplanned way is significantly different to the consequences of, a retail outlet closing in an unplanned way. Neither are desirable, but one is more consequential. That said, we are, as Judy says, we're in regular dialogue with care home providers. There has been significant financial support through a number of routes over the last 6 months, and we are seeing an increase in the number of people moving into care homes. So I think it'll probably there will remain a continuing increased level of voids compared to, say, this time last year, but I think that will start to narrow somewhat. Certainly for some homes. For other homes, it probably will be more challenging. And, that voice distribution is not even. Some homes are almost full, and other homes have got significant levels of voids. So it's not that every home has got a significantly reduced occupancy level. It's a more uneven distribution than that.
Thank you. Thank you, Chair.
Thank you. Councillor Lee Hamilton has just joined the meeting. Is there any questions you may want to ask Councillor Hamilton?
No, thank you, Chair. Apologies for my lateness.
No worries, thank you. Okay, if there's no further questions on that, can we acknowledge and note the report and follow up progress at a future meeting in particular? Highlight key issues or have a summary section.
Yeah.
And also the end of life care service plan that you talked about, if that could be included in a bit more detail in the future, so that you know, members have got that information before they come to the meeting. Richard, are you wanting to come back in?
Yes, Chair. Would it be helpful for the panel to receive the outputs from that independent piece of work about the future of the care home market when it's available?
Yes, please. Yes.
Yeah. Okay. Yeah, if you can forward that on to us. And thank you very much for all your work on this report and for coming this afternoon.
Thank you.
Thank you.
Thank you, Julie. Thank you, Richard.
Yes, thanks very much.
Bye.
Thank you.
Bye-bye.
Okay, and if we can move on to the next agenda item, which is the financial position of the Kirklees Health and Adult Social Care Economy.
Hi, Chair.
And we have
Would you like me to start?
Thank you, Ian, and welcome to the meeting. Would you like to start?
Yeah, thanks, Chair. Yeah, so my name's Ian Correll. I'm Chief Finance Officer for Great Hospital CCG and North Kirklees CCG. I'm really hoping that on the call as well, I think we've got Gary Boothby from CHFT, who's Director of Funds for CHFT. I think we've got John Haig, who's Senior Finance Manager at the Council, and Richard Meller, who's Director of Finance for Locala. I think they're all on the call. What we wanted to try and do in response to the request from the committee was to try and bring the Kirklees financial position together for health and social care. So hopefully we've done that within the report. I'm going to give just a really brief introduction and overview. I'll then give a quick update around the two CCGs that I look after, and then I'll hand to each of the others just to give a couple of minutes literally on each organisation's position. So hopefully that'll take about 10 minutes, something like that, and then we'll open up for questions. Does that sound okay?
Yep.
Yes, that's fine.
Brilliant, fantastic. Okay, so just an overview. So I assume everybody's got the paper. As I say, I want to give an overview of the whole of Kirklees Health and Social Care. So we've included all of the health and social care or the public sector organisations. Obviously, Kirklees patients do go elsewhere outside of Kirklees, so that's not included. And equally, the Kirklees organisations, the CHFT and Mid Yorkshire and others, equally will sometimes treat patients who are obviously outside of Kirklees. But what it does show is for those organisations that are based in Kirklees, it gives their overall financial position. Paper starts off by, if you look at your paper, section 2, it gives an overview for each organisation, looking at the 1920, what we planned to financially do last year, what we actually financially did last year for each organisation, and what our plan for this year is. So I say each organisation will go through their figure, but in overall terms, we had a number of organisations that were planning deficits for last year. I think the good news is that by and large people achieved their plans, and a number of organisations did better than their plans, although there are obviously significant deficits still sat in a small number of organisations. On the next page, within section 2, you'll see the table that just shows our efficiency savings. So each organisation continues to need to make efficiency savings so that we can make sure we spend our money on our patients and our residents, and we don't spend it on things that are waste, and we minimise that waste where possible. So that shows what we've done around efficiency. And then the final bit I just wanted to say from an overview perspective was just picking up around COVID, and I'm sure that'll come up in the questions and in what each of the organisations says. But certainly for the NHS organisations, the regime around COVID, has changed. The financial regime in response to COVID has changed very much in 2021. And in effect, what's happened is instead of the historic allocations that we've received, in the first 6 months of the year, NHS organisations have been given the funding that they've historically spent in the previous year, updated for various elements and adjusted for things that will be purchased nationally. That's largely the position for the first 6 months of our budgets for this year. And then for the last 6 months, and then in addition to that, we've been able to claim for any reasonable COVID costs that we've incurred. But for the last 6 months, we're going to have a change of regime from the 1st of October, whereby the West Yorkshire ICS is going to be allocated a budget. And as a West Yorkshire ICS and all of the component parts, we're going to need to live within that. So I'm sure we'll get into that a bit more in the questions. So if that's okay as an overview, I'll just start with North Kirklees and then Greater Huddersfield CCG, and then hand over to each of the others. North Kirklees CCG. If we go back 3 years, North Kirklees CCG had an in-year deficit of 14 million. So I've come to this committee before. So in effect, in year we were spending £14 million more than the allocation that we were given. Our regulator, NHS England, obviously said that could not continue because in effect we're spending other people's money out in other bits of the NHS, so we needed to bring that deficit down. The following year we reduced that in-year deficit to 11 million, so we're spending £11 million more than our allocation. And then in last financial year, the target we were given by NHS England was to reduce that further to an 8 million deficit, so spend £8 million more than our allocation. Last year, we actually achieved a 4.9 million deficit, so we did better than plan, still a deficit. The bit that's better than plan was really sort of a technical, some technical adjustments we were able to make. So our underlying position is still up nearer the 8 million. We think it's about 7 at the moment for North Kirklees is our underlying financial position. So still lots of work to do on the North Kirklees position. And as we come out of COVID, we're still going to be in a recovery plan process, and we're doing that work now so that hopefully when we come out of COVID next year, we'll have plans in place to continue to improve the North Kirklees financial position. For this year in 2021, so for COVID, as I say, it's almost the financial framework happens in a sort of bubble this year. It's not related to previous years and probably won't be related to latter years either. So in effect for this year, North Kirklees have been allocated a budget for the first 6 months of what it spent in previous years. So that therefore incorporated the overspend. We've then been able to claim back any reasonable COVID costs that we've had over and above that, and that's been funded for the first 6 months. So that's meant as at month 6 we're break even, which is good. But I'll say for the second 6 months of the year, we don't yet know what our budget will be. Our budget's been allocated to the West Yorkshire ICS, and we're in discussions at the moment about what our North Kirklees share of that will be. I anticipate that the financial pressure will be more difficult in the second 6 months of the year than it's been in the first 6 months. And then for Greater Huddersfield CCG, last financial year we had a target of break even. We achieved a £1 million surplus, and that means that we can access that surplus in future years when we need it. So that's really good news. It's a healthier position for Greater Huddersfield CCG, which has been built up over a number of years. We've made promises to our public around investing in our out-of-hospital services, A, to improve those services, and B, to reduce demand on the acute hospital and help there. And I think we started to do that, and we've got a number of examples of when we were doing that, and we set money aside to try and do that as much as we can. But in 2021 is similar to North Kirklees, where we've got this different financial regime for COVID, and again we're break even for the first 6 months of the year for Huddersfield. And in the last 6 months, again, we were awaiting the budget from the West Yorkshire ICS for that. If I hand over to the others and then maybe do questions at the end of that, if that's okay, Chair. So shall I hand over to Gary Boothby at CHFT?
Hi there, thanks Ian. So hi there everybody, I'm Gary Boothby and I'm Director of Finance here at Calderdale and Huddersfield Trust. This afternoon I'm also, in addition to giving a briefing on the CHFT position, I'm also going to provide some information on the Mid Yorkshire position. But and there are obviously similarities, as Ian has just talked about the funding regimes certainly for this financial year, the similarities between ourselves at CHFT and Mid York's position. But if I start by just giving an overview of last financial year for CHFT. So last year we agreed a plan with regulators that would require us to deliver an 11 million savings target. And even after delivering that 11 million savings target, we would still be left with a £38 million gap. So £38 million overspend, spending more than the income that comes in. Of which £28 million of that would be a fund that would be made available to us, which was the Provider Sustainability Fund, and a combination of that and the Financial Recovery Fund. So at the start of the year, we agreed a plan that after receiving those fundings and after delivering a savings target, we believed we would still have a £10 million gap at the end of the year, and that was agreed with our regulators. I'm pleased to say that in the financial year, we actually delivered that plan. Lots of challenges in the year, but we were able to deliver against that plan. Some of that with support from commissioners and working together across the patch. But in addition to that, what we were then funded, an additional £10 million of funding was made available to us right at year end. And this is where other organisations and other systems weren't able to deliver their plans. So they reallocated some of that central funding. And as a result of that, what it did mean is that for CHFT, we were able to deliver a balanced financial position for the last financial year. For this financial year, as Ian has suggested, the finance regime has been very different. I have to say it's been very supportive from the centre. Any reasonable costs that have been incurred have been funded. So the aim from the centre was always to try and get organisations back to a break-even position. So at the start of the year, we were working on plans that would have left us with a £27 million overall overspend, and then that would have been funded through this Financial Recovery Fund, so bring us back down to a neutral position. The whole of the regime changed at the start of the pandemic, and effectively any additional spend, reasonable spend that has been incurred is being retrospectively funded back to organisations. And after 5 months of the year, the value of that for us at CHFT is just short of 12 million. So we've had £11.66 million of additional funding given to us to support COVID. Our actual COVID costs for the first 5 months of the year are £14 million. As Ian's just mentioned, the regime itself, we've been given an envelope across the ICS, so that's the integrated care system. We've been given an envelope of cash that was announced last week, and as a system, we're just trying to work through that to see if we can live within that overall funding envelope. I think, as Ian has suggested, it's likely to be tougher than it was for the first 6 months, and therefore leave us all with some challenge. I don't intend, in terms of the Mid Yorkshire position for this financial year is the same, so break even every month of the year, and they're working forward into what happens from month 7 to 12. Their spend in the first 6 months of the year is £11 million on COVID type items, and a need for retrospective top up of £6 million. You may be wondering why the need for top up is less than the COVID spend, but it really relates to the fact that we've been doing less activity. So because we're doing less activity as an organisation, a lot of our non-pay costs, for instance, theatre consumables, are lower than they would have been for the first 5-6 months of the year. Just to complete this, in terms of Mid Yorkshire's position last year, again, they were able to deliver an overall balanced position on the back of funding that came through the system in totality. The challenge for them was a CIP target of just short of £19 million. I think across all providers, we're all looking at an overall challenge of anywhere between 3 and 5%. But again, a positive position financially for the system. We balanced our books, both ourselves and Mid York's last financial year. We're in balance year to date, and at this point we're trying to work out whether or not we can set a balanced plan for the remainder of the year. And I think that's all I was going to say, Ian.
Yeah, thanks, Gary. It probably makes sense if Richard goes next, so you get the NHS position, and then maybe invite, and then John follows on from the council, if that's okay.
Okay, thank you. So, hello, my name's Richard Miller. I'm Director of Finance at Locala. So, in terms of our financial position for last year, we were targeting a £600,000 surplus, which is about 0.5% of our turnover. And due to non-recurrent savings largely, we were able to achieve a position of £1.7 million in year. We had non-recurrent benefits in two areas. We had underspends, particularly on pay. We had a reorganisation of corporate areas, which meant that we were holding a number of vacancies for a period of the year. And also in terms of investments we were planning on making, we had slippage on those, so they were delayed in coming in and we didn't spend everything that we intended to. So coming into this year, we were planning on a £1.2 million surplus, so aiming to get to the position of being able to show a 2% surplus overall on an ongoing basis to be able to give us funds to invest. In terms of this year, we've had the same responses to COVID as the NHS organisations within the system. So that has meant turning down of a number of our services, so particularly dental services, children's services and therapies, and transfer of staff into supporting the community nursing teams, care home support, the rapid response and the intermediate care services. We have been able to access COVID funding through the CCG, and so we've claimed against that somewhere in the region of £600,000 as of August. And I think the positives out of the COVID element, if there are positives, is that actually there's been a lot more partnership working, a lot more working together in terms of dealing with the fallout and the services that we needed to provide and making certain that we were capturing patients who had an urgent need. So that was positive. We're not directly within the NHS financial regime, so we had a plan for this year, as I say, of £1.2 million. We haven't spent on some of the areas that we turned the services down on, and overall we are on plan for this year. But we have got issues with the efficiencies we had planned for this year haven't really taken place because we've been focused on the COVID response. So across the remainder of the year, we do have the challenge of trying to pick back up on those efficiencies. And we are also continuing to provide additional COVID services, which have been asked for to address both bringing activity back to normal or as close to normal as we can, and some of the additional services to support the COVID consequences. I think that's probably all, Ian. Thank you.
Okay, thanks, Richard. And then just lastly, John, and then I promise we'll then have a question. Then stop talking and invite questions. John.
Hello there, my name's John Haig. I'm Finance Manager in the Council, covering adult social care. I suppose a similar story in some respects to colleagues that have just been sort of talking there. It's very much a story of two halves, really. It's sort of the previous year and then obviously COVID hitting us, and how that changes things. In terms of last year, I mean, the challenge faced very similar to previous years, and they've been well documented in the past. In many ways, they were the same problems of things like rising volume levels, increasing complexity, living wage and rising costs, and a fragile market. And also for the council perspective, kind of reductions in funding over the years, which were averaging about 7%, just over, in terms of funding reductions every year. So all those things were at play last year, bringing into sort of that question of the sustainability side of things. That was certainly last year, as per previous, partially alleviated through sort of short-term funding from government, etc. Such things as the Improve Better Care Fund, Adult Social Care Grant, and the preceptors as well was allowed for us. But we always had that pressure of the sort of time limited nature of that, and the fact that 20% of the budget approximately was bolstered by non-recurrent funding, if you like. So those issues as we got to the end of the year were still in play. Certainly for 1920, in terms of the outturn position, we had savings of 2.1 million to make, and we achieved 1.9 million. In the main, they were on sort of demand-led elements, and they were mainly achieved through strength-based approaches, so promoting independence, focus on individual strengths, etc. And that very much hit on the sort of dom care, home care, and also sort of placements. There was also a bit of an underspend on home care simply because of capacity challenges in the market, and measures were implemented mid-year to try and address that to support providers. And that did lead to an increase in some of the number of weekly hours as we got to the year end, so that was beneficial. And then the other area of note that was a challenge and looked at last year and is ongoing was around the employee base, and ensuring that we had the best understanding we can around the demand, the capacity levels, productivity, and the shape of the workforce that was sort of needed. And that's kind of an intelligence-led approach that sort of is continuing as we speak. So effectively, that's sort of where we got to the end of the year. We broke even in terms of position, and we managed to sort of work within those sort of parameters that we were working to. Obviously, as we hit the start of the year with the pandemic, things changed, and then new pressures, etc., heavily to play. Mainly, we're seeing, as we all have, massive pressures on providers. And they were seeing things like vacancies and empty beds, etc., loss of income, additional costs in the market, cash flow problems, and a general uncertainty. And also a more increase in the demand for the more community-based support, especially dom care. So a bit of a shift in the dynamic from previous years in terms of how things panned out. So as we speak, and all this year, we've been engaging with providers and also health partners on how to support the market. In terms of support we've provided so far this year, there's been a 5% premium on the rates for care homes in addition to the standard uplift. We've had payment for additional and excess bed vacancies. We've tried to help with the sort of cash flow side of things in terms of payment, more in advance than purely in arrears. Payment for 3 days after death in terms of care home residents. And we've also been working heavily with partners on the hospital avoidance and discharge programme. And support for dom care in that sector, etc. We've also had the infection control funding from government, which has also been allocated out to the sector to help with that kind of infection control sort of work and remit. That's been very much closely monitored. It's evolving daily, continually sort of reviewing that and how we continue that support. The main issue as we speak at the moment is managing that in year, but then how does that impact and change kind of the future and how we budget into next year and onwards, and what has changed in the market. So all of those things are in consideration. We are, as I say, doing the various levels of support. We have got funding from government that has come in to the council, but very much a lot of that was not just for adult social care, it was for the council to cover all parts of the council. So there's always that balancing act at play, but acknowledging the sort of need within adult social care. So that kind of covers our side of things, if that's okay.
Yeah, thanks, John. And then just apologies to the committee that Mark Brooks from South West Yorkshire Mental Health Trust isn't able to attend, but their figures are in the pack. And Gary's given an overview for NHS providers that's applicable to South West Yorkshire Mental Health Trust as well.
Thank you for that comprehensive information. Can I bring Peter in? Peter, you have a question? You're mute.
Yeah, it's probably preferable. Thank you. Ian, I'll direct it to you, but I think I'm really concerned. It concerns the NHS side of the presentation. And I'm asking this from the point of view of the ordinary layman in the street. We've heard an awful lot about additional COVID costs and how the government has covered these. But I wondered really whether it needed to, because has not a lot of this been offset by the work that you didn't do?
Yeah, I might bring Gary in just a second because he can probably answer it better from a provider perspective.
Yeah,
But so I'll bring you in, Gary. You do it.
Yeah, if that's all right. So I think it's a valid question that you raised there. I think that the sheer costs of trying to deliver services for the first 6 months, though, have far outweighed any benefit that we've had on the reduction. So just taking the CHFT position, so we've spent £14 million on that we can legitimately badge against the extra costs of COVID, and that's in 5 months. We've asked for additional funding of £11.66 million. So effectively, we've only underspent by £2.5 million on not doing the work. So, and it's a similar picture across all providers nationally. The challenge that I guess we've got, which is an even bigger challenge for the next 6 months, whilst in the first part of the year, to ensure patient safety, which was and staff safety, which was our priority, an awful lot of work was cancelled. The challenge that we've got now is to deliver that work plus deal with any potential further spikes in COVID, which is the actual funding requirement for the back half of the year is much greater than the first half of the year. Hopefully that answers the question, Peter.
Yeah. Thank you, Gary. I mean, that really brings me to a second one, really, and that's Ian talked about when we come out of COVID and the recovery position, which is we all hope that we're going to get there someday. But I just wondered what your contingency planning was in the ordinary everyday trust, your contingency planning for the second wave, and how this is going to impact on the neglected routine stuff that's had to go by the board.
So again, that's another good question. So the challenge that has been laid down, and I'm sure you've all seen, is to try and return to the same levels of activity that we undertook in the last half of the last financial year. So that obviously gives us all a real challenge to do that. In terms of areas such as outpatients, the plans submitted by CHFT and Mid Yorks, we do get to the same level of outpatient activity, albeit that a lot of that activity is being delivered in a different way. So where appropriate and possible, a lot of that will be virtual outpatient attendances, because again, we don't want to expose patients to risk bringing them into hospital settings unless it's really essential. We do still have a challenge, particularly with it around elective activity. So for CHFT, our plans for elective activity, so that's planned operations, if you like, we're talking about getting up to around 80 or 90% of last year's activity. And we're struggling to get beyond that just because of the requirement for space. So the planning at the moment, there is obviously treating COVID patients, you need to leave longer between, certainly for any aerosol generating procedures, you need to leave longer between patients, there's more cleaning down required, lots of other challenges that COVID is giving, even things like waiting rooms. For anybody that's been in the hospital settings, it looks very different as a place to what it did 6 months ago. At this moment in time, I said we've put forward a funding request to get us over the next 6 months, which sees us treating patients again. It's not quite at the same levels of activity we were at before. There are also arrangements in place with the independent sector. So there's a lot more activity taking place in the independent sector. So the private hospitals are working alongside our clinicians and our teams to make sure that patients that really need that care get the care that they need.
Thank you.
Just if I could just add to that, Peter, just financially, in the first 6 months, central government, NHS England have been supportive in the way that we've described. As long as our costs are reasonable, they've reimbursed them. Our assumption at the moment is that in the second 6 months of the year, if we get a major spike, central government and NHS England will remain supportive. But we need to wait and see what, at the moment it's going to be in their hands around the funding.
Right. Thank you, Ian. Thank you. And then just one last one, please. And it might be, again, Gary, more in your sphere. And this is about, again, it's a public perception. There's been a lot of money thrown at things that didn't work. and in particular things like PPE that was no good and so on. And I just wondered what the overall value for money strategy was when you are confronted with something that's a very uncertain buy, and you're told to go out and get it tomorrow morning.
Yeah, again, I think it's a fair point, Peter. I think there was a requirement. So the way that the guidance was issued, there was a requirement, as I say, for all organisations to review their governance structures because of the speed with which decisions were made, and all the costs that have been incurred are being audited separately. So, and until we get that funding back, there is a review that takes place. The Deloitte have been commissioned on behalf of NHS Improvement and in NHS England before that's reimbursed. I think at the end of the day, I think there will be decisions that were made that with hindsight we'd have made different decisions. I think that's inevitable. Yeah. So we know within our organisation, for example, in April, at the bank holiday, we cancelled all clinical staff annual leave so that they were available to support patient care. There's a huge cost in doing that, so we've got to buy back that leave or pay for that absence on other occasions. With hindsight, we wouldn't have done that for some of our community staff. I think we'd have done it for all our acute staff in the acute setting, but we wouldn't have done it for the community staff because the level of activity that they were able to undertake or was required to undertake, when you look at it from a value for money point of view, wasn't justified. I think with regard to PPE, again, lots of decisions were made around PPE, trying to do the right things. I think as a board, we took some board decisions that perhaps went against the national guidance. The national guidance was advising us they introduced something called the push. So what they were trying to do was procure everything nationally, and you were given what they wanted to provide to you. So the Ministry of Defence were distributing PPE, and it was received overnight, and you didn't know what you were getting. We had some of our drivers driving around to get masks from other locations across the country. We've worked together as acutes to say, well, we've still got a small supply of this, we've run out of those, and there was a lot of teaming and lading going on, and we didn't get into recharging each other and things like that because we're all one big NHS when it came down to it. But inevitably, the price that we paid for goods was significantly inflated. Our priority, though, was trying to make sure that we kept our patients and staff safe. And if we had to spend more money than it, and it feels quite uncomfortable for myself as a finance director saying this, but we made what we thought were the right decisions at the time.
Yeah, thank you very much. Thank you, and thank you, Ian.
Thank you. Dave, you have a question?
Yes, it's a question for Ian, I think, on paragraph 3.1. There's a reference there to the CCG's cumulative deficit over a number of years, a figure of 13.7 million. I just wondered, is there a timescale over which that has to be paid back, or is there some flexibility in terms of repayment?
Yeah, thanks, Dave. Before COVID, I can tell you what the answer is. We haven't had confirmed what will now happen because of COVID. So before COVID, there was a trajectory that, first of all, we had to get back to break even. So as North Kirklees, we were 8 million target last year. We should have been 5 million deficit this year, 2.2 the following year. Next year would have been a 2.2 million deficit. So our cumulative deficit would have gone up. And then the year after next was when we would start paying that £13.7 million back. So the year after next, we've been asked to do a £500,000 surplus. So that's the first £500,000 of that back. And then there was a trajectory that went up over that. So it's over a good number of years. But basically, next year was still a small deficit. The following year was to start then building up surpluses and start paying it back over a number of years. We need to now have the discussion once we come out of COVID about any new trajectory for paying it back. But our assumption at the moment is we would still need to pay it back. There was some talk before COVID about, in effect, some deal being done for CCGs across the country with cumulative deficits, and a similar thing's been done with trusts where I think it got converted into loans rather than deficits or PDC rather than loans. Something similar has been talked about with CCGs, but because of COVID, nothing's been agreed. So I'm hopeful that of that 13.7 million cumulative, that at some point nationally they'll agree to write some of that off, but we don't know yet.
Good. Okay. Thank you. And question for, I think it's for John, on the adult social care side. There's a reference to an underspend on home care, and that underspend was offset against an over expenditure on direct payments for this year, I think. I just wonder whether, is there likely to be a problem for funding direct payments for next year?
Possibly. I think one of the problems we're facing as we look at the budget setting for next year is exactly those kind of questions, and it's very hard to pin down. I'd love to be able to, we all would be able to sort of love to say it's going to be X and Y, but we're struggling on that one. It's very much a team effort in sort of shaping that. Certainly what we are seeing in the current year is that the dynamic has changed. Now the home care side has gone up and up and up and up more than we thought it would do, obviously because of COVID. The problem we have in terms of gauging it though is that in place of other elements, and so other things have gone down and would continue to be sort of lower, or will everything go up? And so it's very hard to say. Certainly from last year it is massively different though. We are seeing just a whole new dynamic. In terms of direct payments, that will probably be, I would expect it will still be higher. The one that is going down or is lower that compared to last year certainly is on the sort of placements in care homes. That's the one that's the one that's dipped down. The other ones more community based or direct elements such as the direct payments, etc., and home care, they are the ones that are higher. But it's what bounces back and at what point and what's the new norm. That is the question we're facing. So sorry, I'd love to give you a really specific one, but we're shaping that as we speak because we need to do that and focus on that.
No,
is that okay?
Fine. Thank you. Yeah.
Thank you. Councillor Smage.
Thank you, Chair. I was just wondering, the Mid Yorkshire, I realise the Mid Yorkshire finance officer isn't present, but in 3.3 they're talking about a deficit pre-PSF and able to receive 29 million PSF MRET posted a post-PSF surplus. I just wondered if you could actually just clarify what that is for a start, please. And then comment on, it looks like that a few health bodies have benefited from maybe one-off monies to bring their finances back from deficits this last time, and I just wondered how the health and social care in Kirklees is working together to try and improve financial positions as well as services for people, because there could be a far greater demand for some services going forward into the next financial year, and also the mental health. They're saying about recruitment, problems with recruitment, and I'm just wondering if anybody knows how that is being improved upon, because there's going to be possibly a greater demand for mental health services moving forward. Thank you very much.
Okay, thanks, Ian. I think they're for me then. So apologies for PSF, FRF, fit trajectories. There's you know, the NHS, we love a good acronym. So effectively the PSF is provider sustainability funding, which is also mixed with finance recovery fund, FRF. And for this financial year, they changed it all and called it a financial improvement trajectory. So if you just treat those as one for now. Historically, in the NHS, we get funded for the level of activity we deliver, something called payment by result. So for every piece of activity you do, you get a certain tariff and you get paid that way. Over the last few years, it's become quite evident that I think at one point 80% of acute trusts were overspent, so they had a deficit position. So it was quite evident that the tariff was insufficient to deliver the actual activity we were delivering. But rather than change those tariffs, what they did is they came up with these different funds, the 3 funds that we've just talked about. And those three funds effectively were pots or allocations that were provided to organisations to top up your income. The reason why it was kept separate, though, was because there was still a number of targets on the back of it. So, for instance, if you spent more than they intended for you to spend on agency staffing, you lost some of the funding. If you started to overspend, you lost some of it. So they were trying to incentivise you to deliver your plan pre-Provider Sustainability Fund, pre-PSF, and then you went on and achieved that funding. What happened across the West Yorkshire system was that as a system, we all had to live within the pot or target that we'd agreed to live within, which we managed. But other systems weren't able to do that. So other systems weren't able to receive their provider sustainability funding, and that was then allocated back out to the systems that did hit the target. And on the back of that, that's where in the Mid Yorkshire report, it says that they were successful and they managed to achieve, I think, just another couple of million. At CHFT, we received an extra 10 million. So you received funding to get you back down to break even. The NHS wanted to get the money back out, but they wanted to give it to the organisations that had delivered their plans effectively. The other acronym that's in there is the MRET, which is the Marginal Rate Emission Tariff. And again, that's just another technical sum. I know for CHFT it's worth about £6 million, whereby years ago they used to strip out an element of the tariff that you received, and they've found another way to give it you back based on your performance. So so apologies if that's confusing, but hopefully that answers the questions on how we did across the ICS, how we're certainly working across as NHS partners in terms of the funding envelope. So I think, as we've mentioned a few times, the funding envelope that we've been given for the remainder of the year has been given to the integrated care system, so to the NHS providers. It's between us now to work out, honestly, between ourselves, what we think we can deliver. And it's interesting because obviously we've all got our own governance and our own boards to report to and so on. But this is about how we try and land this position and deliver all the care that we need to collectively between us. And then I think the third question that they had there, Councillor Smage, was around the Mental Health Trust. Last year they did have a number of recruitment challenges. Financially, it gave them a benefit because they were underspent on pay and they were unable to recruit some of these colleagues. This year they're reporting much lower turnover, so their staffing numbers are much higher now than they were, which from a patient care point of view is good news. Financially, it creates more of a challenge. But I think what we're Mark here on this call, the Director of Finance from the Mental Health Trust, he would be calling out some real worries for the next 6 months of the year around the acuity of patients linked to COVID in a lot of aspects. They are seeing a lot more activity. They're seeing a lot more acuity. And also, because of the limited number of beds, they've got some real concerns about should there be a COVID outbreak in one of their units, it would mean a lot more out of area care that was required. So sorry, I can't remember, there were a few questions there, Councillor Smage. Is that covered though?
Can I just pick up a little bit more about workforce, Councillor Smage? Is that okay?
Yeah. I think my question went about was the health and social care as a whole working together as well. But yes, thanks, Ian.
Just on those two bits, just to add on the working together, I think Gary's explained how financially working together. I mean, I do think as organisations we do work better together than one of the things that's improved in the last few years, I think. So I think because there's quite a lot of things happen on an acute footprint. So what we try and do in Kirklees is working on an acute footprint and a local authority footprint. So there are things we do with Calderdale CCG to work with CHFT, and there are things that as a North Kirklees CCG, we work with Wakefield CCG to do with Mid Yorkshire, where those pathways make sense. There's then lots of things we do on a Kirklees basis, particularly when we look at out of hospital care, and there's all the integrated. There was an integrated provider board and an integrated commissioning board, and now there's a joint board, and I can't remember what it's called. But anyway, everyone comes together in Kirklees as well on a regular basis around Kirklees things. And then just about workforce, I just want to say two things on workforce. There is a Kirklees workforce group chaired by Steve Brennan to pick up generic workforce issues. And I just think one good example is actually there's only a certain pool of qualified staff. So we need to think flexibly about getting different and other staff into health and social care. And quite a good example, I think, in primary care is there's now separate funding for doing all sorts of different roles that haven't been in primary care before. So a good example of that would be the social prescribers, whereby each primary care network and GP practice now will employ social prescribers and all sorts of other roles as well. And we've really been encouraging that and funding that separately.
Thank you very much, Chair. Thank you.
Okay, I have a question from a colleague, Leslie, councillor that can't be with us this afternoon. She's emailed a question on Locala finances. Would that be Richard that answers that? She said that the Locala report has made no reference to the huge losses from their care services and wants to know more about this and the impact on their finances.
Okay, so I've probably two things to say. So first off, the report is at top level. The home care is a part of or was a part of the Locala group. So the costs of running that and the losses that we're making supporting it are included within the overall position. It's a service that we've run for a number of years. We attempted to build it up and it was proving uneconomic for us. So that was the point at which we decided to withdraw from that market. We worked with the council in doing so because there was an impact potentially around the services that they were looking to provide that we had been providing for them. But overall, that lost money because it cost more to provide than we were making or able to get in. In terms of the overall position that's presented, those losses took place over a period of time. They were realised because of the structure of the group in last year, 2019-20, but they're included within the overall position that we've got. So it wasn't highlighted separately, but it's a part of the overall position. And for 2019-20, at the point that we were looking at whether or not we were going to stay in that business and could actually make it work, we'd agreed to the fact that we would support it to the tune of about £250,000 in the plan. That was part of the plan that would have delivered the original plan of £600,000 surplus, and the remainder of the funds were what it had cost us over the period of time for the previous 6 or 7 years. I don't know if there's any particular more information that you want, or a particular question.
That's fine for now. If there is anything, we'll email you out of the meeting.
Okay. Thank you.
Okay? Is there any further questions from the panel? Okay. Well, in that case, if we note the report and its contents, and as we're hearing, there's a lot about COVID costs and the impact it's had on some of the service delivery. Can we receive an update in the future of the actual cost that the Trust and its partners have actually incurred? And I'd be interested in the community-based services, the dom care, in the future, if we can have a summary of its impact on the community and how that's being delivered. That would be useful. So thank you to the officers for attending and presenting the information to the panel. We'll move on to the next agenda item, which is agenda item 8. Is this Emily's? Emily?
Hello.
Hi.
Hi everybody, how are you all?
Good. How are you?
I am as well as can be expected under the circumstances, I think is my response to that question.
Well, you've not tested positive, have you?
I haven't, no. I haven't tested at all, but I haven't tested positive. No, I'm well, thank you. It's nice to see you all.
Thank you. Well, this report is really for information, as the panel did want to be kept in the loop on the highlights that were going on around COVID. But given the fact that we've gone into lockdown again this week, you might want to give us a couple of highlights.
Yeah, certainly. Shall I do a whistle stop through the data and the presentation, and then I'll do a bit of a things. Every sentence I start at the moment starts with "as I currently understand things." The other day I spent 20 minutes summarising the guidance for myself, and in the time it had taken me to summarise the guidance had changed. So yeah, as long as you take this as a point in time and as I currently understand things, I'm very happy to do that. Richard, are you going to share the slides and I'll talk through them?
They've all received them. I mean, I can.
Oh right, okay. Sorry, I wondered if you were going to share your screen. That's fine. I've got them in front of me, so I'll flick through them for myself. That's absolutely fine.
Yeah,
no, that's fine. Just means that I can't see all of your faces if I've got the slides open in front of me. So this is our cumulative position as of the week ending the 10th of September. So this is a couple of weeks old, the data now, but it allows me to give you data in which we are very confident because it's been through a series of checks. Obviously, I'm very happy to come back and continue to give updates. So our cumulative position in Kirklees is that we have had up to that point 3,260 confirmed cases of COVID in Kirklees, and in that last week that I'm referencing, we'd had a total of 188, which is a significant increase on the week before, and that we were ranking as a local authority 26th in the country. I'm sure I don't need to remind Scrutiny panel members that at certain points in this ongoing pandemic, we had been in the top 10 in the country, and not in a good way. So the line that you will be particularly interested in on this next slide, the one titled current position, is the turquoise turquoise line. Sorry, that's the line that specifically relates to the Kirklees population. What's interesting, there's a few things that are interesting to note here. One is that broadly speaking, the shapes of the lines mirror each other. So the shape of the line in Kirklees, the shape of the line in England, and the shape of the line in Yorkshire and the Humber are broadly similar to each other. So we've seen increases when others have seen increases. We've seen decreases when others have seen decreases. But we are currently experiencing a period of increasing numbers. As I'm sure you will be aware from local, national, regional press, testing has been a particular challenge. That challenge splits into two parts. Firstly, the availability of testing, and then the testing kits, and then secondly, the availability of labs to be able to process those tests. So this is the position as it currently stands in Kirklees, but all of this is subject to change. So the mobile testing units, we currently have drive-through sites in Batley, Holmfirth, Dewsbury, Fartown. And these mobile testing units are deployable at the bequest of the Director of Public Health, according to our local intelligence. The local testing sites are walk-up sites, and they are currently operating on an appointment-only basis because of the capacity in the labs to be able to process the tests. And they are currently located in Ravensthorpe and Saviltown. We have potential upcoming locations in Earlsheaton and a site that will be agreed with the university. They're in place every day of the week, and they run in those particular locations for a minimum of 4 weeks and are subject to change. Asymptomatic testing, we have been successful in being chosen as a strange term, successful to be a pilot. I'm not sure if successful is the right word, but we have been chosen to be a pilot for a period of asymptomatic testing, and that will be run in our wards with the higher case numbers. Asymptomatic obviously just means those people who are without symptoms. So for some people who are asymptomatic, they will spend the entire period in which they have COVID being asymptomatic, and some people will be in a pre-symptomatic phase and go on to develop symptoms as their illness progresses. The levels of disease that are spread by people who are asymptomatic and the estimates of the level of disease spread vary quite significantly. Initially, the WHO was saying that they expected to see very little spread from people who are asymptomatic, and I've seen some estimations in the last couple of weeks that suggest that asymptomatic people who are asymptomatic could be responsible for up to about 40% of all of the spread of disease, and they vary within those 2 points. So this pilot of asymptomatic testing will be focused in our areas of highest incidence. It will be time limited, and it will be delivered in partnership with the Red Cross. We are waiting to be given a start date for that work. As I've already made reference to, there's been some fairly significant challenges with the access to testing at a national level. And last time I heard anybody from the government talk about this, they were saying that they expected testing to be back to manageable levels by early October. So I'm working on an assumption that our asymptomatic pilot will run along a similar time frame. The second area that I wanted to talk to specifically around testing, so I'm on to the next slide now, which has care homes at the top of it. We have a programme of asymptomatic testing in our care homes. Residents are tested monthly and staff are tested weekly. And I'm sure the panel will recognise that that's because those people who are in care homes, and these are specifically those care homes for those aged over 65 and those suffering from dementia, are our most particularly vulnerable members of our society. So that testing is ongoing. We have a plethora of plans and arrangements in place to support our work, obviously being led by the Director of Public Health. We have a local outbreak control plan that is specific to COVID-19. And that is being implemented. It's being implemented and developed as we go along, because I'm sure, as you can appreciate, this is an emerging situation, and it's for all that I'd had training on dealing with outbreaks in my registrar days, this is not quite what we ever thought we were training for. We have a really robust communication strategy, and I'm really proud of the comms that's going out from Kirklees, and we're getting feedback from the population that's telling us that it's really helping to clarify some of the confusion that exists about what people can and cannot do. We have a programme of mobilising community protection plans. So every week we are assessing the data that we now have access to in terms of incidence and prevalence of COVID within the wards, and then based on that data making decisions as to which wards we mobilise community protection plans in, and those community protection plans mean more boots on the ground, more council staff out there in communities giving messages, helping people to understand what COVID is, what the symptoms are, how you access testing and how you keep yourself and your family safe. There's a group that's specifically working on test and trace, and the panel will know that the NHS app was launched today. That work's all overseen by the Health Protection Board. And then there is, as I'm sure you're all aware, the Outbreak Control Board with cross-party membership. I've just put this slide in because I thought it would be useful for the panel to have as a point of reference, because we talk about outbreaks and incidents as though they are words that everybody uses every day. I thought it would be useful for you to have that as a point of reference, but I'm not going to talk through it in detail. PPE. You've talked about it a little bit with the acute trust. So Kirklees Council has been managing the West Yorkshire LRF emergency supplies during COVID-19. There have been periods of time when the access to PPE has been significantly challenging. But we are, and if everybody could touch wood or cross your fingers or do whatever it is that you're superstitious about, we are currently in a good place with regards to access to PPE. But we have been providing emergency supplies to our community-based providers, and we continue to hold the emergency stockpile. COVID has strengthened a lot of our relationships across NHS providers and councils, and the acute trust finance directors talked about what was the expression you used? Tipping and ladling. I didn't know that expression, but that's what we've been doing. We've been tipping and ladling, and we've been supporting each other. And there is now a national portal open to provide emergency supplies to primary care. So we have learnt an enormous amount about how to respond to a global pandemic. We know now much more about how to engage with our communities, about how to get those messages across. We have incredibly clear messages, and the messages are always the same. The way in which we have to put those messages across into different communities varies, and I'm going to do a little bit at the end on what those key messages should continue to be. But I'm really proud of what we've done in Kirklees, and yeah, I think we should all be incredibly proud of what we've done. In terms of the ongoing considerations that it's worth the panel being aware of, I've already made reference to the changes to the PPE system and the launching of the online portal. Obviously, we are in true Game of Thrones style. Winter is coming, and we are well into the preparation for the seasonal flu programme. And I would actively encourage everybody who is eligible to a free flu jab to access that flu jab this year. It's always important. It's more important than it ever has been. And you've already picked up around the winter and possible second wave with the acutes and the finance directors earlier. Obviously, we are worried about an increase in cases of COVID coinciding with the usual winter pressures that the acutes and providers face. But we are doing everything that we can to try and reduce rates in the population. So that's the end of my presentation. It would be very, very remiss of me if I didn't take the opportunity to say the thing that I always say whenever I have the opportunity, that there are 6 key messages that we really need to make sure are out there in our population. Washing your hands remains incredibly important. Washing your hands well for a period of at least 20 seconds using soap and water, and if soap and water isn't available, then alcohol hand gel. Social distancing, this is a respiratory virus and it spreads on droplets, so it's incredibly important that you maintain social distance from people that you do not live with. It's incredibly important that if you are symptomatic, if you have the symptoms of COVID, which are a new and persistent cough or a high temperature, so if you feel hot to the touch, you don't need a thermometer, or a loss of sense of taste, of sense or smell, then you should get tested. And it's really important that people recognise and remember that that is or any of those things, that it doesn't have to be and. If you do have those symptoms, you should get tested. If you have those symptoms, you must isolate and keep yourself away from people whilst you access that test. And I should never have told you that there were always going to be 6 things that I was going to say, because I've run out of things and I've only said 5. So just bear with me while I look at my note and see where I got up to. Oh, limit your social contacts. That's the one. Really important that where people are able to, they limit their social contacts, because the virus doesn't spread itself, people spread the virus. That was all I was going to say. I'm very happy to take questions and equally happy to come back again in the future.
Thank you, Emily, for that very comprehensive brief. Peter, would you like to ask your question first?
Thank you, Chair. Thanks for that, Emily, and for the update. I suppose if we're to really cut to the quick, is the problem with testing one of demand, or is it capacity?
Capacity.
Capacity.
Yeah.
So we've not got, as we've been led to believe, we've not got people who are time wasting or going asking for tests because they don't need them.
It's probably both and, actually. It's probably both and. I think it is very, very important that at the moment, given the capacity we have in the system, people are only accessing tests outside of the, not outside of the asymptomatic testing pilot and the care homes that I talked about. It is very important that people only access a test if they have those symptoms. But the reason that the testing was reduced last week and the week before wasn't about people presenting for tests in high numbers. It was that there wasn't the capacity in the system to deliver the number of tests that were required. Right. We need more testing.
Right, thank you. Sorry, and then having got over that, I just wondered, please, given that the Public Health England has now been dissolved or downgraded, I just wondered where responsibility now lay between, and what the interface was, I asked you this last time, I know, between yourselves as a Department of Public Health and the National Institute for Health Protection, and between yourselves and Serco, and I wondered where their responsibility for test, trace and isolate stopped and yours began.
So that's a really complicated question, Peter, and I'm really sorry. I'm not entirely sure that I can answer it, but I'm happy to go away and do a bit of ferreting in the background to be able to give you a fuller answer. I just know what I do on a daily basis. So on a daily basis, we are engaged in conversations with Public Health England to ensure that we have testing capacity in Kirklees. I don't know how the technical relationship between Serco, Public Health England, NHS England and Health Protection works, but I'm happy to take your question away and answer it properly.
Yeah, sorry. No, I wasn't really so worried about them as to how you just relate directly to Public Health England. So, sorry to you don't relate to Serco at all.
No.
No. So what do they do that you don't? What are they doing? Because they've got call handlers and a £300 million contract and goodness knows what.
I don't know what Serco do, Peter. I've got enough on working out what I do. But in terms of what we do around the test and trace, where there are cases who have not been contacted by the national team within a certain number of hours, it's either 24 or 72, I'm sorry, I can't remember, we pick up the tracing, the contact of that contact, and then the tracing of their contacts, recognising that we've had more success at a local level. But in terms of what Serco do, I'm sorry, I can't comment on that.
I think you've answered it. I think you've answered it. When they've not managed to do it, you pick it up, and
that would be a summary. Yes,
that would be a summary. Well, that's okay. And then really to come on to the other things really. And I mean, what's your take, Emily, on reporting times?
Reporting times seem to be relatively quick at the moment. I think turnaround time is around 48 hours, sometimes slightly quicker. Speaking personally, I've had a couple of members of my team who have needed to access a test for themselves or their family recently, and they've had those test results back relatively quickly. So where people are able to access a test and there is the capacity in the system to access the test, the results are being returned quite quickly.
Yeah, and you're happy that the location of your testing centres. I mean, I notice you've not got anything in the centre of Huddersfield, anywhere near the bus station or the railway station. You're happy with? Is that because there's no one gets it in the centre of town, or?
No, that's so we are in the process of establishing a Huddersfield Centre testing space. It will be on land that's owned by the university, but will be accessible by the Huddersfield population. There was certainly a bias in terms of where we put the initial testing stations, in terms of, you know, they were where people were testing positive, but there's work in progress to establish a Huddersfield-based test centre.
And what about? I mean, obviously you're prepared for a second wave, and what, you respond accordingly, or have you got a contingency plan that says, you know, this is increasing exponentially, and we know we're going to be able to cope?
So in very typical public health, I am interested most in the primary prevention of trying to reduce the number of cases of COVID-19 that we have in our population. So we are going hard on our messaging in our communities to try and help people understand the restrictions that are in place and why those restrictions are in place. Some of the current government guidance is harder to explain to the population than other elements of it. But primary prevention is key. I was hoping that over this week we would have had some announcements made nationally about the relaunching of the shielding programme, because we need to make sure that particularly those people who are most vulnerable to COVID-19 don't get COVID-19, but there haven't been any announcements made about a relaunching of a national shielding programme. So the key messages are everybody needs to be very careful, but those people who were previously on the shielding list need to be additionally careful in terms of hand washing and social distance.
And what do you? I mentioned this last time, but now that the app is available, what sort of benefits are you expecting it to convey? I mean, I found it's very easy to key into. What it does, I'm not sure, but
yeah, I registered for it this morning, and as soon as I understood the instruction about how to enter my postcode, I got on with it fine, but it took me a little while to work out what I needed to do with my postcode.
I mean, in population terms,
in population terms, I think one of the things that we need to be really, really mindful of is digital inclusion. So for a proportion of our the population and how they use the app will fall into a number of different groups, won't it? It will fall into those people who are very well behaved and compliant like me, and they've been told to download an app, so they do. They've got the smartphone to allow them to do that, and they've got the data available to allow them to do that. You'll then have a subcategory of the population who think, well, I'm not downloading that app, I don't trust it. And then you'll have a category of the population who just don't engage with it and don't realise it. And then you'll have a category of the population who do not have the smartphone technology available to them in order to be able to use the app. So each of those categories will respond to and use the app in different ways. What I hope the app will bring us is an ability to have much more knowledge about where the virus is and how it's circulating in our population. What I worry about with the app is that those people who are not following the guidance, are continuing to go to the pub, are continuing to mix within their households, they're not going to turn the app on, because why would you if you're going to behave in that way anyway? So let's see. It's very early days. The app was only launched, as you say, today. Let's see what data it brings us.
Yes. Thank you very much. Thank you.
You're welcome.
Just on the app, Emily, if I can ask you about, I don't know whether you're aware that there's a scam that's going around, and it's a message from the NHS about track and trace. Yeah. And basically they call you on the phone and tell you that they've been in contact with somebody who's been tested.
Yeah, I've heard about this one.
And they need to go for a test. And they can mail the kit to their home, and it's going to cost them £50. Yeah. And given the fact that you've just sort of said that the systematic testing, you're going to be targeting, a particular area, it could mean that we have a lot of vulnerable individuals there that may even have language difficulties. So something that we need to bear in mind, that they don't fall for that scam.
Absolutely. So I'm sorry, I'm struggling to hear you a little bit, but I think you're talking about the scam that's particularly around people saying you've been in contact with somebody, and if you pay us some money, we'll send you a kit. Yeah. I'm aware of that. So a lot of the work that we're doing in communities is dealing specifically with the kind of the myths and the rumours that exist around COVID-19. And one of the clear messages that we are giving in communities is the NHS is free at the point of use, and you will never be asked to pay for a test.
Okay. And one other thing, there's also messages going around about the flu jab, that it contains pork gelatin. Yeah. And again, we need to get that communication out, because given the fact that we have a high proportion of BAME communities contracting the virus, they're going to be in a higher risk, and that will not take the opportunity to take the flu jab.
Absolutely, yeah, that's part of the comm strategy for the flu jab, for the CCG and us and the council are working on together.
Mm-hmm. Okay, Lynn, would you like to comment?
Yes, thank you, Chair. I've got 3 questions, please, Emily. And my first one is there a specific end-of-life guidance protocol for care homes and hospitals in terms of family members being able to spend time with their loved ones when they have reached the end-of-life stage?
Okay. Do you want me to answer each question individually, or do you want to ask all of them and I'll answer them all at the end? I don't mind.
Yes, I can answer the next. I can ask the next one. And that is with regard to domiciliary carers. Who are going out to vulnerable people in their homes to provide home care. Is there a guidance protocol there relating to how often the carers are tested for the virus, or in fact are they being tested as a matter of course? Mm-hmm. And my third question is one I've asked before actually, but now that the virus infection rate is escalating at a fast rate of knots, I don't think I've ever had the answer, so I'd like to ask it again please, and that is there specific guidance regarding the PPE that should be put on, and when it should be put on and when removed, with specific focus on home visits, and also how is it disposed of once it's been removed following the visit, and how is it safely stored in the meantime, for example, if someone is using their vehicle to travel around to make those home visits?
Okay. Thank you for those questions. In answer to your first question around the end of life protocol, in Kirklees we are in an area of additional restriction. So that means that we are actively there are some things that we are legally not allowed to do. That includes visits in private homes or gardens, or visiting other people's private homes or gardens, and then we are being strongly advised to not do some other things, and one of those other things includes visiting family in care homes. However, it is recognised that particularly where people are at the end of life, not being able to visit family would cause enormous distress. So there are exceptions being put in, and people are being supported. As I understand it, Richard Parry would be better placed to answer this question in terms of the specific support from care homes, but people are being supported to be able to visit people where it's recognised that they are at the very end of their life. Your second question was around domiciliary carers and the guidance on testing them. The only asymptomatic testing programme that we have in place at the moment is for care homes. So it's specifically for those staff and residents of care homes. There isn't a programme of asymptomatic testing for domiciliary carers. So if they are symptomatic, if they have those symptoms that I outlined previously, then those people should get tested and they should isolate whilst they wait for a test result. But there isn't a programme of asymptomatic testing for domiciliary carers. And then your last question around the specific guidance on PPE and the donning and doffing prior to home visits. Yes, absolutely. There's guidance that's been issued, and I'm really happy to get a copy of that for you and share that after this meeting, if that would be helpful.
Yes, that would be very helpful, please.
I will do that with pleasure.
For us all to have that. Just to go back to my first question, what's the position about visiting people in hospital who have reached the end of life?
I believe that the position in visiting in hospital at end of life is the same as the position in visiting for people in care homes. I think that the both acutes have got protocols in place to support people to be able to visit at the end of life.
Is there any possibility we could see those as well? Or is that
I don't have access to those. They would sit with the acute trusts, but I'm very happy to take an action and see if I can dig a bit deeper into that for you.
Is there a possibility, Emily, that could change, considering that we're looking at a second wave and we don't know what that's going to look like?
I think that the only thing that we can be certain of at the moment, Councillor Zaman, is that all of this will change.
Dave,
but I'm very happy to try and have a look into that for you. I'll send an email and see what I can get.
And I think the only other point I'd like to make, because I'm conscious of time passing, is in relation to the fact that the domiciliary cares are not being tested. And I'm just wondering whether, in light of, you know, as we've mentioned, the increase, the massive rapid increase in the infection rate nationally, whether that ought to be reviewed.
Yeah, I mean, ideally, we would have a programme of asymptomatic testing for all of our frontline staff, and within frontline staff, I would include teachers and I would include social workers, because those are the people who are going to keep the country going. We currently do not have the capacity nationally to undertake that programme of asymptomatic testing, and that's not something that I am in control of. But I agree with you. We should be undertaking asymptomatic testing on a broader level.
Thank you, Chair.
Thank you.
And we still have another item that we need to look at. Dave?
Yes, excuse me. It's a question on tracing. I just wondered, are you getting access to all the patient identifiable information that you need from Public Health England now?
Yeah, we're getting data now.
At the right level?
It's better than it was. It could still be better, but
Right.
we're getting a minimum data set that supports the work that we need to do.
And do you hope to be able to get the further information fairly soon?
Yeah. I'm hope what we're working on at the moment is a business case to support us undertaking more localized contact tracing as well. And as part of that business case, there'll be a data sharing agreement that will be signed up to by between us and PHE.
Right. Okay. Thank you.
Thank you for that, Emily. If we can note the information that Emily's been able to share with us, this will be a regular item on the agenda, and because it's ever changing, if there is any questions, feel free to either email myself or Richard, and then we'll be happy to send it on to the appropriate officer for information. And if we can thank Emily for attending, and
you're welcome. It's nice to see you all. If we can get them in my diary going forward as soon as possible, because it's pretty chocker at the moment.
Well, Richard, Chair.
I think Emily, they are in your diary.
Brilliant, excellent. Well, I look forward to it, and I'll see you all again soon.
All right, thank you.
All right, everybody, take care. Keep washing your hands. Bye bye.
Thank you. Bye.
See you then. The next item is the Adult and Health and Adult Social Care Scrutiny Panel Work Programme. If we can just quickly scan through that, and like we mentioned earlier, due to the number of meetings and virtual meetings, we're not going to be able to go through everything that was on our wish list. And if Richard, you want to come in at this point.
Yeah, thank you, Councillor Zaman. Yeah, I mean, I think to be honest, the big issue for me was just to make sure that members were comfortable in terms of what we've got coming up on the programme, and also to have a particular focus on the December meeting. So if I can just confirm that as things stand for the next meeting, which is on the 5th of November, we have currently got winter pressures on the agenda, which obviously is something I know that you're all very keen, obviously, to cover. So we will have representation from all of the key NHS and social care organisations attending that, to give you an overview in terms of what they're doing to prepare for winter, and obviously we'll take into account the situation regarding the pandemic. We have also got a item covering the Kirklees Safeguarding Adults Board. They come each year, if you remember, to present their annual report. And again, I know this was something that you were quite keen to obviously get onto the agenda, so we've got that one as well. As we've already mentioned, we've got the COVID-19 update, which is a standing item. And then also what was alluded to in our first item today is that we have provisionally put down an item to cover the findings of the independent analysis of the likely future size and shape of the older persons care home market. And I'll need to liaise with Richard Parry on that one, just obviously to make sure that that is feasible to come to that particular meeting. So it's quite obviously a busy agenda in terms of the next meeting. As far as December's concerned, we currently have an item which again links on to the analysis of the older persons care home market, where we believe we should be in a position to be able to present to you the action plan in response to the findings of the analysis. But again, I'll need to clarify that the timings of that with Richard Parry. But at the moment, that's provisionally on. And then we've got the COVID-19 standing item. So at the moment, for December, we've got those two items. I think probably we could manage to get another item on the agenda. So I guess, Councillor Zaman, what I'd be really appreciative of is sort of some guidance from the committee in terms of what, looking at the work programme as a whole, if there are any particular areas they see as a priority, which we can maybe start to bring that forward to be covered at the December meeting. So obviously I'd leave that to panel members and yourself just to give me some indication of what you think we should be looking at for that December meeting.
Particularly the fact that we're having fewer meetings and the virtual, there's only limited capacity, so therefore we need to be much tighter in our thinking and what we bring to panel. So, well, if people have got ideas, we'll quickly go through that. Lynn, do you want to go first?
Yes, thank you, Chair. One of my concerns, as everyone knows, on an ongoing basis is support for people experiencing mental ill health. And I think it would be useful to get something in a bit more detail directly from South West Yorkshire Partnership NHS Foundation Trust about the worries that were referred to today for the next 6 months, and the fact that there's been a lot more activity due to the negative impact of the COVID-19 virus. And basically the concerns about what will happen if there's an outbreak on an inpatient psychiatric ward, and the knock-on impact on the use of out-of-area beds. And I just think it would be useful. I know we've got a focus on the different parts of mental health services where we look to have a workshop, and we've also got a focus on suicide prevention. And I think it all fits in together really. But I think our key priority at the moment is to get a little bit of an understanding and some insight about what's happening, particularly in South West Yorkshire Partnership NHS Foundation Trust.
I agree with you, Lynn. Maybe that is something that we should prioritise. Dave?
Thank you, Chair.
Yes, I was referring to it's item 4 on the programme, the quality of care in Kirklees and the CQC, and particularly the focus on adult social care, because I think last time round we didn't get a presentation on that, so that might be relatively high priority perhaps.
Okay, that is something again we can I can have a conversation with Richard outside of this meeting and look at that. Okay, is there any further comments on that? Yeah, you can always email myself or Richard outside of the meeting, and we can have a look at the items. Okay,
Councillor Zaman, I think Peter's indicated he wants to speak.
Sorry, Peter.
No, I did, yes, thank you. Now, all I was going to say is, might there be some, I mean, I do support everything that's being said, both Lynn and Dave's suggestion, support that entirely, but might it be as well to just hang fire, because we could have events overtake us with a second wave. And COVID could collide with winter pressures in a bigger way than we've all thought about so far. I know that's nebulous and a bit vague, but do we really have to pin something down now? Was my question.
We don't have to pin it down now. We've got the agenda for the December meeting, but it's just something that we wanted to put into. We wanted to put the ball into your court so that you're aware that it's something that we are looking at.
Yeah, I think Councillor Zaman, we've obviously got the COVID standing item around the COVID update, so that may well cover some of the issues that obviously Peter has raised. And I can certainly contact CQC and touch base with them, but my worry is I think if we start to put too much onto the agenda, again, as always, it might we've got to work it so it's manageable. And I do know that mental health has been mental health services have been sort of like an ongoing concern across the whole panel. So I suppose, subject to your approval, my inclination would be to probably focus on the mental health issue as a priority for December, but I will touch base with CQC as well and just sort of get a feel from them in terms of timescales if they were to come to a panel when they could do that.
Mm-hmm.
Yep, it's good.
Yeah.
Yeah, that's absolutely fine. Yeah. Okay. Well, thank you. That brings us to the end of the meeting. And,
sorry, Habiban. I thought Liz indicated she wanted to say something.
Sorry, Liz.
It's okay. No, it's all right. Just really quickly, health inequalities, not necessarily for the December meeting, because obviously things might change, as Peter said. The Health and Wellbeing Board are responsible for looking at health inequalities, but I just wondered if the Health and Social Care panel would want to take some informal information to start with on how health inequalities is being looked at in relation to the health and social care, what they're calling restart of services. And I just wondered if that would be something later in the year that the health panel might be interested in.
Yes. Definitely, Liz.
Yeah.
Yes.
Yeah, that's fine. Yeah. Okay, thank you for that, Liz. Is there any other further comments before I close the meeting?
No.
Okay. Well, thank you very much, everyone, for attending and for your valuable contributions. They've been much appreciated. And I'll see you at the next meeting.
Thank you very much.
Thank you, everybody.
Yeah, thanks. Bye now.
Right, take care. Keep safe.
Bye.